Day 2 of our refresher course in Neuro-Otology. It's an honor to host such prestigious premier colleagues speaking for this event today and yesterday. Today we are going to start with none other than Diego Kaski, who, as you know, is a well-known physician scientist from University College in London. He's an associate professor there, and he has been around for many, many years doing groundbreaking work in the field of neuro-otology. Stage is yours, Diego.
Thank you very much. I'm going to share my slides here. Okay, so hopefully everyone can see the slides there. It's a genuine honor to be part of this international event. I know that many people are sharing very different time zones here, so appreciate everyone's participation here. I'm going to talk about persistent postural perceptual dizziness, and we'll focus quite heavily on the clinical aspects of this rather than the scientific endeavors that have happened in this area. But we'll of course feed some of that scientific knowledge that has allowed us to understand this disorder better as I go along. Dizziness, as everyone knows here, is exceptionally common, and no matter how hard some doctors try and stray away from managing a dizzy patient or seeing dizzy patients, that's almost impossible. And whilst for the patient, dizziness is rarely life-threatening, but almost always life-changing, the same is often true for the physicians dealing with these patients. There's this sense that dizziness can be a very difficult and challenging symptom to deal with. And I think this is particularly salient for patients that have chronic syndromes. Flipped on its head, for the patient, there's a real frustration for the lack of understanding, the sense that their symptoms really aren't taken into account when they have chronic dizziness. And I think there's a prevailing sense across many non-specialists that when patients manifest chronic dizzy symptoms, the primary issue is anxiety or a mood disorder. And I think there is a lot less of an appreciation how, in fact, much of that anxiety, which for sure exists, is underpinned by some other underlying vestibular disorder. And really 3PD is a prime example of this, where the consequence of chronic symptoms really manifest as profound psychological disorders that are very much intertwined with the underlying vestibulopathy. So we're going to talk a bit about the actual syndrome itself and try and understand its neurobiology, and then at the end I'll touch a bit on the treatment approaches that work here, and hopefully that will lead way to Mercedes's talk after mine. So some definitions. I think the key here is to understand that this disorder, 3PD, is not new. Although its definition has been updated fairly recently, patients with this condition have been around for millennia, and it has, over the course of many years, changed its nomenclature based on what our understanding of the disorder is like. And I suspect that in years to come, we may see more changes in how this is termed as we begin to unpick this a bit more. So the terms such as chronic subjective dizziness, phobic postural vertigo, visual vertigo, space motion discomfort are all familiar terms if one looks at the older literature in terms of understanding the disorder. And it's fair to say that these disorders, these classifications, were often used interchangeably across the literature. And now we begin to understand them more as functional neurological symptoms, which allows us, although it's an umbrella term, allows us to try and heterogenize the syndrome a little better. And this will, of course, help, not so much in the clinical realm, I think, because I think that regardless of what you call the disorder, these are the patients don't really care so much. It's more about understanding what's going on for them. But I think in terms of the research side, it certainly helps to have a term that everyone understands, and which allows us to make a more definitive diagnosis and feed that into a clinical experimental trials that take place. So the preferred term is currently 3PD, and I think it encompasses many of the symptoms that are listed in the previous definitions. There is a diagnostic criteria that was generated after a lot of discussion from the Barani Society, And I think this was phenomenal work really to try and put together such a complex disorder and trying to better define some of the diagnostic criteria that are used. These here are the published criteria. I'm not obviously going to go through each of these individual elements, but I think it's important just to have a feeling for what sort of patient this represents. In my experience, and this isn't necessarily everybody's experience and certainly not what is published elsewhere, but in my experience, there is less of a divide in terms of male and female predominance for 3PD. And I think we see more men that we perhaps do compared to other chronic vestibular disorders such as vestibular migraine. I think there is a slightly closer matching of genders for this disorder. There is a very broad age distribution for 3PD. We see young patients with it, 17, 18-year-olds, and we can also see much older patients with this disorder. And I think that is something that is true across most functional neurological symptoms. It isn't true that it's a disorder just of young people or middle-aged people, in fact. So we do see it across the board. And the typical patient is one that probably had some sort of early insult, some abnormality, whether that be a true vestibular insult or some other medical disorder that then transforms into a more chronic and persistent form. And with those come a persistent symptom load that need not be present every single minute of every day, but is certainly there most days of the week and for most of the day, with clear fluctuations. And there will be good and bad periods of the day, there'll be good and bad weeks, and there'll be maybe even good and bad months for these individuals. And the predominant symptom that is described is one of dizziness, but that's obviously a very vague term. So what most people report is a sense of motion in the absence of any physical movement. And that internal sense of movement tends to take either a rocking type sensation or a discomfort when they're walking around their environments. And as the name suggests, this is a predominantly postural syndrome. So patients are most symptomatic when they're upright and walking around, and tend to be relatively less symptomatic, although symptoms rarely go away completely when they're more sedentary, lying down in bed, for example, or sitting down doing very little. And part of the postural aspect of the disorder, and I think one of the reasons that this was previously termed visual vertigo, is the very strong sense of visually induced dizziness that I will come to in a bit, just to understand what we mean by that. So these patients often become very visually dependent. They rely more heavily on vision than they need to, and that often causes a lot of discomfort when they're exposed to busy visual environments. So as with most definitions of vestibulopathies, the final aspect of the diagnostic criteria is that symptoms are not better accounted for by another disease or disorder. And this is in many ways an essential but disappointing feature of the diagnostic criteria, particularly for something that's so complex and doesn't have a clear test that one can do to pick out the abnormality. So in fact, it's very difficult to be completely definitive about 3PD and exclude any other possibility, given the complexity of the symptoms that we're dealing with. And so I think from the clinical angle, one has to be quite pragmatic here. And there is a general fear, I think, of making the wrong diagnosis in medicine still. And this is particularly true for functional psychogenic disorders. I think we're less scared of calling someone Parkinson's disease and slightly more scared of calling someone to have a functional tremor. And I think the same is true for dizziness. There is a real fear that one may overcall functional symptoms in dizziness. And I think for 3PD, this is a bad thing because we rely very heavily on the diagnostic label and an understanding of the disorder for the recovery of patients with the syndrome. And I think if one doesn't make a diagnosis early on, that often will lead to a poor long-term outcome in these individuals. So I think it's good to understand that there exist diagnostic criteria, but one does have to be quite pragmatic about how many tests one does on them and interpreting these with some caution. I need not remind the audience, I think, how common 3PD is in clinical practice. It's said that about 5% of GP referrals are referred with a constant sensation of dizziness from a fairly old epidemiological study now. And in approximately 1% of all outpatient clinics, one will expect to see someone with persistent dizziness. In our own practice, we see very high numbers, and I think that in part is because of the nature of the clinical work that we do, we tend to see the more complex patient population with vertigo, and therefore we see between 25 and 40% of patients with this in a typical clinic. It's also unsurprising, I guess, given the persistent nature of the symptoms, that has very strong functional implications for the individual, with severe limitation of social activities, big problems with work and education, with lots of days off work, difficulty with their social life more generally, so the difficulty with relationships with friends, and a degree of cognitive impairment that I think is perhaps under-recognized for 3PD, much like other chronic symptoms, whether that be pain or something like vestibular migraine that is episodic, but can be chronic and give long-term cognitive impairments. The same is true for 3PD. And this is a graphical representation of the natural history of the disorder. So if we look at the symptom load here on the x-axis and the time along the y-axis, we see that the typical presentation is with an acute episode. And in this example here, this is vestibular neuritis, so you may have an attack of vestibular neuritis with a very high symptom load over a very short period of time, and then there's gradual recovery, and the majority of patients will recover over this time frame completely. But there are a proportion of individuals who, as they begin to recover from the original insult, begin to develop more low-level, less severe, but more persistent symptoms that will tend to fluctuate over time. And this is what 3PD is all about. And this is an example for vestibular neuritis, but the same is true for someone that may have recurrent episodic vertigo, such as PPPD, or even vestibular migraine, such that may have relapsing and remitting type of symptoms at the beginning, and then towards the middle of their presentation, they begin to experience a more persistent state of dizziness that never really leaves despite these fluctuations. And of course, it's worth remembering that in patients with 3PD, particularly those that have a recurrent underlying pathology, their underlying recurrent pathology may coexist with 3PD. And so you may have an even more complex picture where you have something like vestibular migraine or BPPV ongoing through 3PD symptoms. And that's why the clinical history in the examination is so critical in these individuals, to try and really understand what the drivers to the chronic symptoms might be, and therefore trying to tackle not just 3PD itself, but also some of the triggers that may be persistent and ongoing. I talked a bit about visually induced dizziness. This is, of course, an extreme example. You don't tend to faint with it, but there is a general sense of a severe discomfort in the face of busy or rich visual environments, and the typical scenes that tend to lead to visually induced dizziness symptoms are supermarket aisles, repetitive fences or striped shirts, disco lights, movies, flow of the river, clouds. So a variety of normal environmental factors that will lead to this. And those that study vision from a scientific perspective, so visual scientists will tend to call this a visual overload, and that's sort of what this represents. And I think for patients also, it's quite useful to take this symptom and expand on it when you're making a diagnosis, so that they can understand what it is that's causing that discomfort. And this term, visual-induced dizziness, which is, again, fairly recently incorporated into our literature, used to be called visual vertigo, and stems from a lot of work in the early 1950s that looked at the degree of visual dependence or field dependence that individuals have. And this is something that we all as humans have to an extent. We rely on vision for our balance. That makes logical sense. But an over-reliance on vision can be counterproductive. And the reason for that is that our eyes are designed to take in visual information, but they cannot disambiguate between visual motion that comes from the outside and visual motion that is triggered by our own movements. And whether you are moving or the world around you moves will induce the same retinal slip in the eye. And therefore, patients that are very reliant on vision will experience a sense of self-motion when faced with external motion, because the eye is unable to differentiate the two. And this visual overload is very much part of the general motion overload that exists in patients with 3PD. And when I talk to patients, I tend to describe this as the volume in the brain being elevated. It's too high, it's too loud. So much like in vestibular migraine, where you get photophobia and phonophobia, or patients with 3PD often have a degree of motion sensitivity, which is in part related to this increased hyperexcitable state that the visual cortex is in. And this is a picture diagram that has become, I think, a centerpiece for 3PD, that is borrowed from a paper by John Stone, published some years ago now, who I think quite elegantly describes the neurobiology of this disorder, that starts with some sort of structural physical abnormality, and that precipitant may be, in the case of 3PD, a vestibular problem that might be Meniere's migraine, PPPD, or indeed some other medical problem. So they may have had a heart attack, they may, the myriad of triggers for this problem. And then this structural abnormality in a susceptible individual who has quite strong psychological variables that will make them much more likely to develop 3PD, such as pre-existing anxiety, high levels of neuroticism, or in clear psychological distress during this precipitant event. These are the individuals that will likely develop 3PD. And of course, there is a group of individuals who will have comorbidities where many of these things will be active at the same time, and others in whom that structural event will have completely gone by now, and they're left with just 3PD symptoms. And the complexity of the treatment will depend very much on where within this Venn diagram these patients sit. And as I've said, the causes of 3PD are myriad. There are almost limitless triggers for this disorder. And although as neuro-otologists, we tend to focus very heavily on the vestibular causes, I think it's worth remembering that it's not just a vestibular insult that can trigger 3PD-like symptoms. This is probably the only sort of scientific slide that I'm going to show here. And this is work that has been pioneered by the Italian groups in conjunction with Jeffrey Stabb in the States, that have looked at some of the functional imaging changes that occur in 3PD. And of course, this is the most relevant investigation, if you like, to tackle, because 3PD is very much a software abnormality, much like the other functional disorders. The problem lies not so much in a structural event, but rather in a disconnectivity or misconnectivity between cortical and subcortical areas in the brain. And what they have identified by exposing these individuals to the functional MRI scanner in the context of either symptoms or indeed by inducing discomfort through visual stimulation or self-motion stimulation, is that there is an abnormality in connectivity in key cortical areas. And those cortical areas are primarily centered around the vestibular networks, posterior insular, superior temporal gyrus, and the visual cortical areas, where there is a degree of abnormal connectivity in these regions. And again, perhaps unsurprisingly, there is a strong element of abnormality in function within the limbic areas in the brain that process emotion. And whether that is a primary problem or a consequence of the chronic disorder, of course, is not clear cut, and I suspect that probably a combination of the two. Certainly, this disorder is one of limbic abnormalities. I think one mustn't move away from a psychological model of 3PD completely. And although that isn't the sole explanation, it's actually integral to the disorder itself, and therefore, again, very important to tackle that when it comes to treatment. So this is all fine, but how do we actually make inroads in explaining to the individual what the problem is? And can we try and make, as with other functional disorders, a positive diagnosis rather than, as we saw in the diagnostic criteria, trying to exclude any other possibility? And the short answer is that there may be a way of, in the clinical setting, making a diagnosis more confidently, and in fact showing the patient what the abnormality actually is. So I tend to use this technique, which is to ask the patient to stand in the rhombic stance, so feet together, eyes open to start with. And when the eyes are open, I ask them how they feel. And often patients with 3PD, with feet together and eyes open, will feel a bit unsteady, maybe a bit of disorientation, a mild fear of falling. They don't feel perfect, but certainly they're relatively stable. You then ask them to close their eyes, as you would for a Romberg's test, and you again ask them what they feel. So you're really exploring the subjective element of the Romberg, and then comparing that to the objective response that you see. And most patients with 3PD will experience a severe degree of motion with eyes closed that is not manifest in the objective movement of the trunk. So there is a clear mismatch between how they feel they're moving and what is actually physically happening. And that is something that one can use. I sometimes even record the patient when they're doing this, obviously with their consent, and then show them the video of what their actual movement was like. And it's this mismatch, I think, that is critical to the symptoms and the subjective perception of the symptoms that patients report. And in my mind, this reflects a scaling mismatch. Afferent signals are coming in, they're entering the body through the periphery, whether that be vision, the inner ears, or proprioception. And then there is a misprocessing at the cortical level, or subcortical levels perhaps, where the signal is scaled upwards, so that a small movement for the patient becomes a very large one. And this is something that we have seen not just in 3PD, but we've recorded this mismatch, this subjective-objective mismatch in individuals who have unexplained dizziness. So I will touch on that disorder because I think that it, in my mind, is a very interesting parallel to draw between patients that have unexplained dizziness versus who are usually elderly versus patients with 3PD. So although I've labeled this 3PD in this figure for the sake of the talk, this data actually comes from patients with unexplained dizziness in the elderly in relation to cerebral small vessel disease. And what this graph shows is, on this axis here, the subjective instability, and here the sway path, so how much the body was moving in centimeters on a posturography. If we follow the control data here, we will see that, let's choose a sway path. For a 180 centimeter sway, their perceived instability is about 5. If we now look at the patients with unexplained dizziness, and I suspect also those with 3PD, for that same level of sway, their perceived instability is much higher, so approaching 8. So the body's moving in the same way, but the perception is what has changed. And this is really what I think underpins the disorder. And also allows us to make inroads in the clinical setting by doing a Romberg's. So cerebral small vessel disease is a disorder that we're trying to unpick gradually. We have some publications on this already and a few others about to come out looking at EEG and also MRI changes that exist in these individuals. They're usually elderly individuals who have been through a whole gamut of investigations to try and understand their dizziness. Nothing is found on tests, and therefore traditionally their dizziness was unexplained. We have found an association between the degree and location of cerebral small vessel changes, which are here white matter hyperintensity changes in the brain of these individuals, and the degree of dizziness that they report. And we believe that this disorder is, like 3PD, a disorder of connectivity or disconnectivity between cortical and subcortical regions that process visual and self-motion signals, together with a dysregulation of blood pressure that occurs at the cerebral level. And the reason that this is, in my mind, quite important as a distinguishing feature is that patients with 3PD often will not have any abnormalities on their tests, MRI or otherwise, whereas the structural counterpart of that disorder appears to be this unexplained dizziness, which I think may share very similar neuroanatomical substrates. So I'm going to just touch on the general management of these individuals. There are some, I think, general principles that apply to chronic vertigo and are particularly salient for patients with 3PD. The first is the explanation. And I think that this is an area that I'm a strong believer of. And we hear the importance of an explanation for vestibular disorders in many talks. And my personal experience with giving talks and saying things like, it's really important to explain the problem to the patient, because that will ensure that their recovery is quicker and more prolonged in the long term. In real terms, what does that mean? How does one explain it? And I think that's really where the art comes in. Saying to someone you have 3PD is not going to help them. So just giving them the name is not really what we mean by the explanation. The explanation comes with a breakdown of what is actually going on, but not in scientific terms, because patients mostly will not be able to take that away and understand it. It has to align with their own belief system. And this is what is, in my mind, fundamental for this condition. And in order to make a positive long-term outcome, there has to be an understanding of what the patient believes is going on. So one has to start with the question, what do you think is happening? Why do you think that you have these symptoms now? And it's through understanding what the patient has and then aligning what we understand by the disorder with that, so that you then bring the patient into your model of 3PD, but only through their own belief system. That cannot be enforced upon them. If they think that this all started because they ate a dodgy Big Mac 3 months ago or 6 years ago, telling them that this is all about connectivity abnormalities in the brain is not going to cut it. So I think you have to somehow embed that Big Mac into your discussion. And that genuinely is where the art is in the explanation comes from, I think. And then you have to remember to treat related symptoms. So there may be neck pain, there may be migraine, they may have other psychological or even psychiatric problems that may need addressing in their own right. And they mustn't be forgotten, because they will likely be precipitants for that chronic symptom. And then finally, worth remembering that drugs, particularly anti-vertiginous drugs, don't really have a strong role to play in chronic disorders of this nature. So prochlorperazine or Stemetil, cyclizine, cenarizine, beta-histine, these aren't going to help the patients. Some drugs may do. And there haven't been very many studies looking at treatment for 3PD specifically, although there have been some previous studies looking at chronic subjective dizziness, for example. And there's a general consensus that medications can help. So this is the dizziness handicap inventory across a number of weeks in a patient with chronic subjective and patients with chronic subjective dizziness that were treated either with sertraline alone, which has a beneficial effect over an 8-week period, or the combination of sertraline and psychological treatment with cognitive behavioral therapy, which has greater impact on their symptom load. So it looks like medications may have a role to play, and the combination of medications with CBT is even more effective. And there are a number of medications that we routinely use. Jeff Stabb in the US, I think, is a very big fan of both venlafaxine and sertraline, although many other medications are typically used. And the general experience with using these medications is that they can be effective even in patients who don't have a very clear mood disorder. And in my mind, patients with 3PD often have an underlying increased anxiety level that is not necessarily akin to a panic attack. They don't have recurrent panic attacks necessarily, but there is just that elevated sense of hypervigilance for the body. And I think that's one of the features that we often see is sort of hypervigilant state for bodily functions. And this is part of the reason that these medications can be effective. But I am a proponent of combination treatment, and I think this is a dynamic disorder. It's a postural disorder, and therefore this is not just treated with a drug and psychotherapy. Patients need to move. They need to be re-exposed to movement, because if you don't do that, the patients are only going to develop greater and greater avoidance behaviors. So my treatment of choice is what I call cognitive physical therapy. It is a physical rehabilitation that takes into account CBT measures to try and change that abnormal perception of what is happening, to try and rescale the afferent signals down, to try and reduce the hypervigilance state, and then therefore create a much more normal behavior for that individual. So yes, psychological therapies, possibly antidepressant medications, yes, physical therapy. I think it has to have that combination. Some individuals will not improve either at all or very much. And I think that's something that one has to accept in these patients. I tend to have a very positive outlook with them at the very beginning, and I always emphasize the potential for recovery, because I think there is, all patients have potential for recovery. But those who have very strong psychological issues, or maybe have issues in the home, have legal issues regarding their 3PD symptoms, are much less likely to make a strong recovery. And I think I would never give up on them, but I think at some point one sometimes also has to accept that there are some individuals who will not recover from this. But fortunately, that's the vast minority of individuals. So I feel like I've spoken enough. I'm just going to briefly summarize. 3PD is a chronic, persistent vestibular syndrome, common across neurological practice, but probably way beyond that also in general medical spheres. It is an abnormality of disconnectivity between visual and vestibular networks, and also involving limbic structures. And treatment has to include tailored cognitive physical therapies for that individual. If I'm allowed, I'm going to just make a plug for a course that I'm running now virtually on the 8th of December, looking at dizziness and balance in London. So anyone that's interested in taking part in that would be very happy to welcome you there. I'm going to stop there, and I can see, I think there are some questions that have come up. So if I let's see if I can stop sharing my screen. Okay. So I think there are some questions there. Am I allowed to target them now, or shall we wait for the next talk?
Go ahead.
Yep. So there is one question from Sudhir, I think, and said, is this analogous to central sensitization in chronic pain? Why the word perceptual? Isn't all dizziness perceptual? Do they get vertigo, or is it only dizzy imbalance? All good questions. Thank you for that, Sudhir. So in some ways, it is analogous to central sensitization in chronic pain. I think there are lots of similarities between 3PD and chronic pain syndromes. And in fact, many other specialties, cardiology, renal medicine, will have their own version of 3PD. And I think the mechanisms that underpin 3PD are probably very similar in those disorders. The difference perhaps is the anatomical structures involved, that in some generate pain, and in patients with 3PD generate dizziness symptoms, but the mechanism itself probably is similar. Absolutely to perceptual. I mean, all dizziness is by nature perceptual, and as one of only 3 neurologists in the UK that have an interest in this, I find it amazing, because for me that is what dizziness is. It's a neurological disorder because it's cortically driven. It's a percept. Now you might argue the same for pain. You would argue the same for many other symptoms that are felt. The reason that the word perceptual is included here is because, contrary to many of the other disorders that cause dizziness, which are percepts, in 3PD, one doesn't find a physical explanation beyond the perceptual disturbance. Whereas in conditions such as PPPD, there are objective abnormalities that one finds, and therefore I think it's more relevant to include perceptual for 3PD for that reason. And then finally, do they all get vertigo, or is it only dizzy imbalance? In my experience, the majority will experience a sense of imbalance, spatial disorientation. They do get vertigo in as much as there is motion, but it's rarely true rotational vertigo. There are some that do, and I think the ones that experience rotational vertigo, I have a few patients who have a constant perception of rotation, so that the world is constantly spinning in front of them. Some report constant oscillopsia. I think that's much more in the functional realm. Those individuals often have a very strong psychological or psychiatric basis for the disorder. And in many cases haven't had a clear vestibulopathy at the trigger of it. So they represent the vast minority. The majority of patients will experience an imbalance primarily, or a vague dizziness feeling. Can't see any other questions unless there are any that have come to you directly.
Sorry, like we have in chronic pain, if the person feels threatened, if he feels that this is dangerous, then the pain doesn't go away. Is a similar thing for triple PD, that as long as he feels it is something dangerous, it is something threatening, it is difficult for him for it to go away.
Correct. I mean, I think that's the hypervigilance aspect of this. The raised anxiety level is sending a fight or flight message constantly to the individual, saying that something's wrong, something's wrong. And for as long as the patients feel that nothing is found, that fear that something is going on will be there. So the label, the explanation, is trying to tackle that. It's trying and reassure the brain, the subconscious level of the brain, that there is nothing going on, so that then these signals can die down and patients will no longer feel that there is a threat to their life in some way. Dizziness generally is one of the few symptoms, I think, that causes a complete loss of control for the individual. And it's that loss of control that's so scary. And I think for 3PD patients, that's what they go through on a constant basis. You know, so you can understand why the hypervigilant state manifests.
Yes, and I think to some degree, maybe we can say it is iatrogenic because, for example, I've seen patients who get an attack of micturition syncope and he gets admitted, and at the end of he gets a cardiogram, he gets a stress test and an angiogram, and you know the whole works. He's admitted in an ICU, and in the end, they don't tell him clearly it was just micturition syncope. Or a BPPV patient, they say it's spondylosis, then somebody says it's less blood supply to the brain. So when the person feels that they do not know, the doctor does not know what I'm having, that tends to cause more triple PD.
Absolutely. And I think I completely agree. And I think it's true of almost all acute vertigo presentations. There is a general lack of confidence amongst non-specialists in dealing with acute vertigo, and therefore very high levels of misdiagnosis. And I think that's certainly, from my research perspective, that's a major focus of my research, is to try and improve acute vertigo management, because I think that makes the biggest difference to the individual in the long term. But I agree with you completely. I think if patients that had an acute vestibular problem that is, you know, if they're diagnosed appropriately at an early stage, they are very unlikely to develop chronic symptoms. So in many ways, you might consider it to be an iatrogenic issue. Yeah.
Okay, Dr. Padsala from Surat, he's asking you, what about escitalopram in management of chronic vertigo by which he needs triple PD, and do you use it, and how long do you continue it?
So I would argue that there isn't much evidence for this, but I would guess that it doesn't really matter which antidepressant you use. I don't think it's specific to the antidepressant here. I think that anything that will try and dampen down this hyperexcitable brain, that will try and dampen down this increased anxiety that exists, is likely to be effective. So whether that is escitalopram or citalopram or sertraline or duloxetine, I think probably makes little difference. What makes the biggest difference is the understanding of what's going on for the patient, together with trying to dampen down these issues. I think a drug on its own is not going to work, and that's really my point, is that in many ways, like I think for vestibular migraine, it's not necessarily about which preventative you use, it's how that preventative is used and with what context it's given. If you tell somebody this is what you have, they believe what you have, and you say we're going to treat it with candesartan, that individual is more likely to have benefit rather than having, flunarizine that is the best drug, but if you don't explain the symptom to the patient, they're not going to get better. So I think it doesn't really matter which drug itself. Some individuals need it, and those that need it, I think, are the ones that have very clear anxiety problems or a clear mood disorder. But the majority of patients that I see with 3PD, I don't actually use medications in very frequently.
Yeah, I think it's more the patient believing that you know what is happening and you reassuring that. So then even if you give maybe, as I call it, homeopathic or tiny doses of an antidepressant, also it works. Just one more question, Dr. Antonio Navas asked you, what about calcium antagonists and beta blockers?
Yeah, so we use a range of migraine preventatives in patients with 3PD in whom the predominant trigger was a vestibular migraine trigger, or in whom they have continued to experience migrainous features. I think for 3PD itself, it probably doesn't have a role, but for patients who have 3PD as a consequence of vestibular migraine or together with vestibular migraine, certainly beta blockers, calcium channel antagonists, and angiotensin blockers we use very frequently in those individuals. But I wouldn't say it's a specific treatment for 3PD.
Okay, and the last question, somebody whose name is not known, is a lot of people with triple PD complain of neck pain and stiffness. What can be the reason for that?
So I think this is true not just in 3PD, but in dizziness generally. And one of the reasons that cervicogenic vertigo is so popular worldwide as a concept is that neck pain, neck stiffness, and obviously symptoms on head movement are so prominent in patients with dizziness. And in my mind, it's usually a consequence of the dizziness rather than the cause. So if you are dizzy, one of the mechanisms that the body will try to establish is to reduce your own movement. So if you move your neck less, you will have less motion sensitivity. And that's the reason that they get neck stiffness, as opposed to the neck stiffness being the cause of their dizziness. So I think in some individuals who have very severe neck stiffness, who come to clinic without moving their heads at all, physiotherapy for those individuals will be very helpful. But again, it's not a neck problem that is causing the issues.
Okay, great talk, very nice. I think we can go to the next one, Asif.